everyone, my name is Danielle McFall and I work for Clemson Extension as a health extension agent on the Rural Health and Nutrition Program team in Greenville County. My primary program focus is with the Health Extension for Diabetes program. I've been working with that program for about 3 years under a grant funded by the Greenville Health Authority.
And hi everyone, my name is Melissa Bales and I'm also a health extension agent on the Rural Health and Nutrition Program team for Clemson Extension in Greenville County. My program focus is a diabetes prevention program, and I've been working with that program in extension for about a year and a half under the same grant by the Greenville Health Authority.
So today we're going to be sharing more with you about what we're doing in Greenville, specifically the diabetes prevention program and a diabetes self-management education support program. So we are not only providing quality evidence-based education and support in the community, but we're also evaluating the effectiveness of these programs in community settings.
Both diabetes and prediabetes are growing problems nationally as well as here in Greenville County. According to the 2020 National Diabetes Statistics Report, about 34.5% of adults had prediabetes and 13% of adults had diabetes in the United States. In South Carolina, in 2018, these numbers were as high as 9.6% for prediabetes and 12.6% for diabetes. In Greenville County specifically, DHEC approximates that there is between 9.5 and 10.3% of adults were living with prediabetes, and between 8.5 and 12.9% of adults were living with diabetes in 2018. For people diagnosed with prediabetes, research has shown that by making healthy lifestyle changes, they can reduce their risk of developing type 2 diabetes by approximately 58%. People diagnosed with diabetes, making healthy lifestyle changes can improve blood sugar and reduce the risk of complications. The rates of prediabetes and diabetes have continued to rise over the years. It shows that we need to take action not only to prevent the development of diabetes, but also to help those with diabetes improve their self-management to prevent complications.
So as a result of the problem of prediabetes and diabetes in Greenville County, Prisma Health Upstate, Clemson Extension, and Clemson University of Department of Public Health Science partnered together to be part of the solution to prevent the increasing rates of prediabetes and to help those who have already been diagnosed with diabetes. So each of these three partners play a fundamental role. Prisma Health Upstate functions as our clinical team. They offer a clinical linkage and support for the education programs and the participants themselves. Clemson Extension is the one who delivers the education programs, and we are leveraging Clemson Extension's history as a trusted community resource. And the Department of Public Health Science facilitates the data collection as part of a rigorous evaluation of both programs. So as we've talked about, there are two arms to this project, the Diabetes Prevention Program and the Health Extension for Diabetes Program. So Melissa's going to start talking about the first arm.
The first arm we're going to take a look at is the Diabetes Prevention Program. So this program is part of the Centers for Disease Control and Prevention's evidence-based National Diabetes Prevention Program. It is for people who have prediabetes or who are at a high risk for developing type 2 diabetes. The goal of this program is to help participants lose 5 to 7% of their starting weight, increase their activity to at least 150 minutes of moderate activity per week, increase their knowledge and increase their skills for other behaviors related to preventing or delaying type 2 diabetes. And throughout this year-long program, participants meet 27 times for an hour-long group education and support session and receive a weekly one-on-one health coaching follow-up phone call. So to date, we have enrolled 141 participants in this program across 12 different cohorts. Of those 12, we've had 5 complete the full year, and they have a retention rate or a graduation rate of about 66%. And this is compared to the national average for this program, which is around 30%. On your screen, you now see some of our demographic information for the Diabetes Prevention Program. Participants are majority female, Black, and over the age of 50. And in addition, 36.88% of participants come from an at-risk or distressed zip code. Participants in these zip codes were classified based on what they gave us for their zip code, and the Distressed Communities Index, or DCI. This index takes into consideration a variety of factors related to a community, such as education level, poverty rate, number of adults not working, share of housing that's vacant, median household income, and change in employment and establishments. Our goal is to bring programs into these communities as much as we can. Now let's take a closer look at what exactly is the Diabetes Prevention Program. So initially, when we started this grant, this program was delivered in person only. However, when the COVID-19 pandemic hit, we had to shift to virtual delivery. Between May and August of this year, all ongoing in-person groups were shifted to online. And after the transition, we now have all of our groups meeting through virtual platforms, whether that be over Zoom or through a conference call, whichever the group kind of decided together that they wanted to continue with the program. Also, during this transition online, we had one group graduate from the program, and about a 67% graduation rate. And we've also started about 3 new groups for the program that will meet completely virtually through Zoom for the entirety of the program. And so because the Centers for Disease Control and Prevention already allows this program to be delivered online, the session content and materials didn't have to change at all. But the biggest change that we did have to make was modifying our activities and that interaction piece that we have with the program to fit with those virtual delivery platforms. And so through this switch to an online program, we've been able to reach some individuals in the community that might not have been able to join the program before. This includes people who might work but not want to attend an evening class, and also mothers attending with their infants. And it's also helped us develop the processes needed in order to continue offering this program virtually in the future, past the pandemic. But with this shifted online delivery, we have run into a few barriers. So the first one we've encountered is the limited channels of recruitment. In the past, we've recruited primarily by going out into the community and discussing the program with the community members face-to-face. We are currently restricted to maybe an online recruitment method such as Facebook, Eventbrite, ads in newspapers, and so there's not as many community members who can hear about the programs. Another barrier we've faced is collecting the weight and activity minutes for each session. While in person, these measures are collected at the start of each class by one of our team members. But now participants self-report these things to us either over the phone or through Qualtrics, which sometimes isn't always completed. So we've had to kind of work to figure out how can we get this information while transitioning virtually. But even though we have had a few barriers, overall, the Diabetes Prevention Program has been able to well adapt to the current pandemic to continue to provide this needed education program to the Greenville community.
And so the second arm of the grant, the Health Extension for Diabetes program, is for individuals who have already been diagnosed with either type 1 or type 2 diabetes. The program goal is to provide participants with the knowledge, skills, and support that they need in order to better manage their blood sugar so that they prevent or delay complications related to diabetes. Our program has a total of eight sessions, each of these being an hour long, and delivered every other week. And in between the core education sessions, the participants receive weekly health coaching or follow-up phone calls. The core education sessions cover the AADE's 7 self-care behaviors. So to date, the Health Extension for Diabetes program has enrolled 281 individuals, and so that's spread out over about 20 cohorts. And between all of our cohorts, our overall retention or graduation rate is about 98%. Participants in the Health Extension for Diabetes program are majority female, identify as Black or African American, and are over the age of 65. In addition, about 37% of participants come from either at-risk or distressed zip codes. It is important that evidence-based education support programs are available, especially in these at-risk and distressed zip codes, because individuals living in these areas may not have access to healthcare services for education and support because of their various socioeconomic barriers. The program was initially also designed to be delivered 100% in person, but we also had to adapt and to deliver the programs online as a result of COVID-19. So starting in April 2020, the program shifted to an online delivery platform. So just like with DPP, the program itself did not have to change. All of our session materials and the facilitation of the core education content remains the same between in-person and online delivery. But in order to stimulate and facilitate group support that may be lacking from having to do something virtually, we added an optional support group session between the core education sessions. And so these support groups are more informal, and that allows time to review resources, provide additional support for any barriers, and give the participants time to celebrate their successes as a group. The support groups are structured for consistency, but they are flexible enough to meet the needs of each of the groups that are meeting together. This is something that would happen naturally for in-person programs, discussion that may happen before, during, or even after our in-person meetings. So as a result of this transition, we've had two primary successes. For one, we've been able to reach a different group, just like with what Melissa said earlier about the diabetes prevention program. We've been able to really reach a similar demographic that we had not been able to before. So working middle-aged individuals, also parents with younger children. And so others that have had barriers to coming to our traditional in-person classes, whether it be for timing in the evening or during the day, difficulty with traveling, being able to join online and participate virtually has been helpful for them. And so another success too, we've been able to partner with additional physician practices and doctors to actually have some sort of referral system, which was not something that we had in place for individuals joining in-person programs. So during COVID, a lot of the physician practices had a change in their operations, maybe not seeing patients in a clinic or in an in-person setting. So they were actually able to review additional records to actually make some of these referrals for a community-based program. As a barrier, again, similar to what Melissa said with the diabetes prevention program, we were also collecting weight in person at the beginning or at the end of the session. And so now the information has to be reported. And so sometimes that can be a little bit more difficult for actually having people to input that information, and it's self-reported weight versus actually being able to take their weight with the same scale between each of the participants in different cohorts.
And so, as we mentioned, these programs are part of a research study. And with that, we have a very robust evaluation. So not only do we collect weight and activity like we've mentioned in our limitations, but we collect a lot more. And there are some similarities between collected for each program, but there's also some differences. Programs, we collect basic demographic information, weight, A1C, specific knowledge, physical activity, nutrition behaviors, patient activation measure, or PAM, self-efficacy, and general health status. So these are all the measures that we collect for both, but also all that we have for the diabetes prevention program. This evaluation for the diabetes prevention program, it's really important that we collect information such as weight and activity, not only for the research and evaluation component within this grant, but also for when we report quality outcome measures to the Centers for Disease Control and Prevention.
And so for HED, or the Health Extension for Diabetes program specifically, we collect information about specific self-management behaviors like foot care, medication adherence, blood sugar monitoring, but then we also ask them questions related to any existing complications that they may be experiencing. So for the Health Extension for Diabetes program, some preliminary analysis has shown some promising results. And so what we've seen, this is specifically for our in-person groups, from pre to post program participation, weight, BMI, physical activity, and even knowledge has improved. So participants have had have seen weight loss and improved BMI scores, along with an increase in reported physical activity minutes and exercise health behaviors, all of those being critical components for diabetes self-management. In addition, we've also seen a statistically significant increase in diabetes-related knowledge, which again, if people understand more about what diabetes is and how to properly self-manage, then that's correlated with better self-management as well.
And so with a preliminary analysis of the completed in-person cohorts for the diabetes prevention program, it also shows a lot of improvement in pre and post-program measures. So participants in this program decreased their BMI, improved their overall health, increased their knowledge, and increased their physical activity, all of which were statistically significant changes. So all of these factors mentioned here with these changes are important when we're thinking about preventing or delaying diabetes. And so both of these programs show promising results related to improving the health of residents here in Greenville County and working to combat this growing problem that we're seeing both on a local scale and a national scale for prediabetes, diabetes, and diabetes-related complications. Clemson is a land-grant university, and we are so proud to be able to partner with health systems and funders to provide this type of unique service to the citizens of Greenville County. We're bringing the best of Clemson to the community with these health-related extension services, combined with strong research that enables us to provide a program that improves the health of those living in South Carolina. So we thank you so much for listening to our presentation today, and we now welcome any questions you may have about our talk. Thank you.